She's going to be Vanna Lakewood. She's going to go around the microphone.
Oh, okay.
Yeah, yeah.
Well, just like that, you're very attractive. You could get your hair blonde. So, questions. This is the chance to put Joseph on the hot seat, me in the hot seat, whatever you want to do, you know, stump the doctor. So we'll take the one at the back. Well, get a microphone.
Yes.
Yeah. So, while you're taking the microphone back,
Yeah.
right at the back.
Yes. Back to the back.
Yeah, yeah, yeah.
Yeah, yeah.
Hustle, hustle. Thank you for your patience. I know it's hard to sit here. So, CTV at 6 o'clock, Global at 6 o'clock, and CBC Radio at some time. So far.
I've heard that there's people with MS that have been tested for the blockage and don't have blockage. What happens then?
So let me address that. A really good friend of mine from Calgary actually went to Poland, and she was told she was in that 3%. I didn't address that directly, I should have. Poland presented in Italy 1,000 cases of people that have had the so-called gold standard of injection of dye and looking at X-ray to see if you have blockages or not. They found that 97% of people with MS had CCSVI blockages. I would suggest, and I took hers, because she was told she was in that 3%, I took hers down to Pacific Interventional, showed them to Michael Arata, and he said, she has lesions we could treat. So I would suggest to you, if they weren't found, they weren't looked for correctly, and even on speculation, the valves should be treated if you don't find the localized region. The reason for that, flow through a tube is related to the fourth power of the radius, so-called Poiseuille's law. What that means is a small reduction, even 30% reduction in the flow through that tube is a profound reduction in flow if it's that much narrowed. And I think if you're looking at 50%, you're going too aggressively. So many of those people should be treated anyway. That would be my suggestion. And I think you will find, you know, the folks that know it best. The other advantage of you know, Michael Arata and his team that he's put together along with Joseph, of course, is if people have CCSVI, they'll treat it. Some people won't touch it unless you've got MS. Now you've got reverse discrimination. Okay? So you need to get retested, and we will find over time that we'll test it differently. I neglected to mention, there was a couple of flow engineers, you know, real wizards. They talk in numbers and formulas I don't even understand. Joseph is an engineer before he did medicine. So, but they will have a test within 2 or 3 years. They'll put a light little cuff around your neck, and it'll test your flow. Plethysmography. It'll be brilliant. It'll make follow-up a GP option. All right? So we'll have that for better testing. And now, because the MRI, MRV that they do there with the Heike protocol, and because Joseph spent extra time training with Dr. Heike, so he can interpret those and they can get them to you, report by the next day, you now got a much better picture of what the whole vascular venous tree is doing. They can look at it in 3-dimensional. It's almost eerie the way it looks on the screen, all right? We can find out more. The ultrasound echo color Doppler does not test the azygous vein at all. It can't. It's in the wrong place to look at with ultrasound. So those of us that have been told we're normal, we might even have normal jugulars. But I would suggest that there's something wrong with the azygous then, or the vertebrals, or both. I don't have a right vertebral vein. It's not there. Other questions? Where's Vanna?
For Dr. Hewitt,
There you go.
you didn't mention rupturing, tearing, or anything of the valves. I'd like more information on that, and then which valves that you do rupture or tear or whatever the word is.
Sure. I try and stay away from words like rupture and blowout. It tends to freak people out a little bit. You know, what we found in our practice, we get perhaps 4 to 5 people a week who come to our practice who have had their symptoms resolved for a number of months and then they recur. And what we see when we look at them with a Heike MRI and also with a venogram is that this valve has been stretched but it's recoiled. I liken the valve to an O-ring, a very stiff O-ring, something like you might find in your car or some piece of mechanical equipment. And that O-ring can be stretched, but in many folks it seems to slowly, gradually recoil. And I think that's where a lot of the 50% restenosis perhaps comes from. In our practice, for about a year now, we've been taking that O-ring up to the point where it just gently tears. And what we found that when we tear that O-ring, that the incidence of recurrence of symptoms, and presumably restenosis, has decreased significantly, closer to the numbers that are being found in the most recent studies that were presented in Italy. We do that almost all the time in most patients in both the right and left jugular veins. Most patients have a valve at the apex of that shepherd's hook of their azygos vein, and we'll often treat that too. In fact, it's very interesting to hear Dr. Code talk about people who've been described as not having the problem. We see a large number of patients who bring us their studies, and we're always happy to look at your studies if you just want to send it to us and get an opinion. And they're told that it's normal. Quite often we will blow a balloon up inside the azygos vein because the azygos vein, sometimes in 2 dimensions, it'll look like it's normal and we don't see that there's a problem until we blow a balloon up inside of it. Some of those patients as well are patients who have had a mild narrowing of their jugular vein, but when we blow a balloon up at that valve, we see that it is a stenosed, it is abnormal. And we have a lot of experience with venous obstructions, especially this May-Thurner syndrome. You can have a very subtle narrowing, well not subtle, let's say a moderate narrowing of your iliac vein in your left leg, and it's not something that affects your life overnight. But over the course of 20 to 30 years, that subtle pressure difference caused by that narrowing, resulting in a flow abnormality, will cause people to have varicose veins and swelling of their left leg and DVT in their left leg. And it's the same idea with CCSVI. It doesn't take a whole lot of narrowing of that jugular vein over a very long period of time to lead to, this increased pressure in your jugular veins that is presumably causing increased iron deposition in your brain. I hope that answers your question. Anyone else? Your choice, man.
Yes, I'm wondering about the MRI, MRV. Are you looking for very specific symptoms, or are you looking overall at the health of the patient? That there could be something else going on besides perhaps MS or fibro or Parkinson's? Maybe there's something else happening?
Well, I think the answer is yes and no. The reason we like to do a Heike MRI in our practice, perhaps to address the latter part of your question, the MRI portion of that exam looks at your brain just like a normal MRI would. An MRI that you would get for your MS perhaps once every year or every other year, looking for lesions, other structural abnormalities. The Heike MRI also looks in very good detail at the flow of the veins in your head, neck, and your chest. And in a sense, it's like doing a Doppler, but we get very exquisite and detailed measurements of that flow, which will point us in the direction of flow abnormalities and suspected stenoses. The MRI is very useful, as Dr. Code described, because it gives us a nice picture of all of your veins. To some of the patients who come down, I liken it to having a map of Los Angeles. I'd much rather have a map of Los Angeles before I try to drive across Los Angeles. It just makes it a lot safer. I don't end up in Watts, right? There are certain anatomic configurations of your azygos vein, certain narrowings that we see in your jugular vein that will change how we do the procedure and actually make the procedure a lot safer if we know about it ahead of time. And of course, the MRI also allows us to measure the iron. And I want to make it clear, that's not going to change how we treat you initially. But presumably, if iron is as important as we think it is, it may help us track your disease in your future. It may help us track response to treatments or medications. So it's good to have that baseline before you get treated. And perhaps one of the most important things, at least for me, as someone who reads a lot of these MRIs, I like to have a study that I can compare to. If in the future, at some point, years later, you start to have a recurrence of your symptoms, it would be nice if in Canada, you could go to your local MRI and get a Heike MRI, rather than someone going inside of you and having to inject dye inside of you, do an MRI so that we can compare the numbers on your flow to the numbers you had before your treatment, and to see if there really is something wrong. Now, this is the whole idea. We want to take a picture of you rather than go inside of you in order to determine if there's a problem. That's why the MRI is good, in my opinion.
You have a question here?
Hello. I'd like to know if there's anything for Alberta.
How do you mean, anything for Alberta specifically, or all of Canada?
MRIs and...
Yeah. Well, the MRI technology exists here in Alberta. I think there's 2, maybe 3 Tesla 7 MRIs. This is a very, very much more potent. Most of them are 1.5 Tesla. Tesla's the guy that described lots of these magnetic field issues. Okay? There's a 7 here at the University of Alberta. I couldn't get on the sucker. No. Well, call it inside connections, I couldn't get on it. They've got a very restrictive protocol to who gets on it. Is it busy all the time? No, not even close. There's another one in UBC, and I think there's one down in Eastern Canada. All right. Foothills Hospital in Calgary is about to install a 3 Tesla. So the Tesla, the one I was on recently down in Newport Beach, you know, was a 3 Tesla. The pictures are amazing. I also was amazed when I had my extensive MRI in Buffalo, and I had a similar one with the Hickey protocol in California. They did 1 millimeter slices, and it took an hour and 40 minutes. Has anybody had an MRI in Canada lasting more than an hour? Okay, well that's great. One of you have. I would suggest we're doing slices of about 3 millimeters or 5 millimeters, and we're missing detail. Okay? Now I know why we're doing it, because we're doing it to save money and get more people through the system. Okay? But we're not comparing apples and apples. And I think some of us are even left in limbo with diagnosis with the so-called McDonald criteria, because we haven't had as detailed an MRI. But we do have the technology. It's accessing it. And you can guess who controls access to it.
What if you can't have an MRI? What if you have a artificial heart valve?
Yeah. We can and we have done the procedure without an MRI. Some people come to us with Dopplers. People who have had a procedure previously, in our practice we don't need an MRI. We prefer the new patients have the MRI for the reasons I've described, but it's not an impediment if you have some reason that you can't have an MRI.
Maybe I could address the issue of stents in MRIs. Some will be an issue. But the other one to address is folks with, I think it would address it. Well, no, the revision of the challenge stints from before. Can you talk about that,
No, you know, people do ask us about stenting an MRI. First of all, if you do get a stent, you can get an MRI. There are some older stents. The metal that has a problem in a magnet is iron. If you were to put an iron wrench in a magnet, it's going to fly all over the place. Most common modern stents are made out of an alloy that doesn't react to the magnetic field, so they're safe. Most people would say after about 6 weeks that stent's not going to move anyways, because there's a skin that grows inside of it. So we can, if you have a stent before, we can see inside of it with the MRI. It's really not a problem, MRIs now or in the future, if you have a stent.